Thank you all for being here. My name is Bethany Ulrich. I'm a development associate with the Epilepsy Association. I appreciate you all being here for our May seminar, and I'm happy to see all these faces. First off, a few housekeeping items. Today's program is going to be about 60 minutes, and at the end, we're going to have a Q&A session. So just as we go through, if you have any questions, go ahead and type them in the chat, and we'll discuss them at the end. And make sure that your computer microphone or phones are muted at all times. We will be recording this program. Then the recorded seminar is going to be posted to our YouTube channel later, and everyone in attendance today will receive a link in their email when that is online. I'd also like to thank our sponsors from SK Life Science. Their generous support has helped us underwrite the cost of hosting today's program. Please visit their website or contact your local rep directly. This information is also going to be shared in an email after the seminar. Now, I'm honored to introduce today's speaker, Dr. Michael DiSano of Akron Children's Hospital. Today, we are hearing Recognizing and Understanding Seizure Types. And now I'm going to toss it over to Dr. DiSano, and he can start the presentation. I'm going to stop sharing.
Great, thank you so much. Bear with me one second while I share my screen, and then we'll get started. Wonderful. Are you guys able to see my screen? All right, wonderful. So as Bethany mentioned, my name is Dr. DiSano. I'm a pediatric epileptologist at Akron Children's Hospital. I've been with Akron Children's now for about 5 years, a little over 5 years. And prior to that, did my training and fellowship at the Cleveland Clinic. So I've been here in the area, Northeast Ohio now for going on, well, since I was a medical student, actually. So even still going back probably now, yeah, like 12 years. So it's nice to be speaking with you today. I'm going to be speaking today about different types of seizures and epilepsy classification, more specifically. And we'll kind of just jump in. I don't actually have a disclosure slide. I don't really have anything to disclose. We're not going to be talking about any treatments or products, really. This is going to be more of an overview about what seizures are and how to recognize the different types of seizures. So I didn't even include a disclosure slide, but I don't have any disclosures. So what is a seizure? As an epileptologist, you know, my primary practice is seeing patients for seizures, particularly pediatric patients for seizures and epilepsy. But I still get a almost daily question about what an actual seizure is. So my way of explaining it to patients is that I tell patients it's an abnormal change in the normal electrical.
I think we've lost audio.
Yep.
Is everyone else able to hear Dr. DiSano?
No, I was just going to put in the chat.
Microphones. Can you hear me now?
Yes, you are back
Yes.
now. Thank you.
Okay, sorry about that. So what I was saying was, you know, essentially, these are all different ways of describing the same thing. But my preferred way of describing it is it's an arrhythmia in the brain. It's essentially a change in the normal electrical rhythm, which the brain has, into an abnormal rhythm, which is what it is. And so here's a screenshot of an EEG of a normal awake brain rhythm. And these screenshots are not of patients of mine. These were actually taken from a recent review paper written by Dr. Weber in the Continuum Journal. So these are not my pictures, but essentially this shows you the normal awake brain activity, as well as some things that we call artifacts that you'll see on the EEG. And I don't have this picture here to kind of break down the EEG or go over what these things are, but just to say that there is a normal awake pattern, electrical rhythm in the brain. And then when it changes, it's to an abnormal rhythm. That's what we call a seizure. In this case, everything inside the two red lines is effectively a seizure. And everything before that and after that is normal brain activity. In this case, this is what we would refer to as generalized seizure. My patients, as many of them will know, I tend to go over a lot of EEG with some of my patients. And so just in short, the horizontal lines here represent the electrical activity between pairs of electrodes, with these top lines representing the left side of the brain, this next set of 5 lines representing the right side of the brain because they have even numbers, and then left, right, and this is what we would refer to as a generalized seizure, because it affects both hemispheres of the brain simultaneously, and we'll talk a little bit more about that, the differences. This is another type of seizure. Again, pictures taken from that same paper. In this case, it's a focal seizure involving only the electrodes on the right side of the brain, primarily in the right temporal region. Okay. So what is a seizure? It's essentially a sustained brain activity change or brief electrical change associated with a clinical finding. They can be seconds, they can be minutes, they can be even longer. Thankfully, that is rare, but when that happens, we tend to call that status epilepticus, a seizure essentially longer than 5 minutes that's not stopping on its own. And this isn't a medical emergency. A seizure essentially has parts to it, though. It's like a story. It has a beginning, a middle, and an end. Now, you may not be able to see, quote unquote, see all of these parts, or any of them for that matter. There are such things as silent seizures, seizures that occur only in the electrical rhythm of the brain, but that don't have any manifestations to them. There are different phases of seizures. There's the prodromal phase, which is not really part of the seizure, but we'll talk a little bit about that. There can be an aura, that can be the middle phase or the ictal phase, and then the end or postictal phase. And so we'll talk a little bit more about each of these phases. A prodromal phase tends to be what we describe those behaviors or feelings that patients with seizures or epilepsy may have that can occur typically hours to days prior to the seizure. Generally, this is not felt to be part of the seizure, but it may be a warning that a seizure may be coming. Certainly not all patients experience this. However, when it does happen, sometimes patients can use that information to take steps to prevent the seizure, i.e. increase their medicines or whatnot, or if it's a shorter period of time before the seizure, at least take steps to prevent injury from a seizure. Now, the aura is usually the first symptoms of the seizure itself. And so it's actually considered to be the initial part or part of the actual seizure itself. And usually it represents a focal seizure. And it's thought of as the warning of something happening. Now, patients will describe a variety of different auras prior to or during, with their seizures. And it really depends on where in the brain the seizure may be starting or coming from. It could be a feeling, a sensation, an abnormal thought even, or a behavior. Now, it's usually stereotyped, meaning it's the same from time to time to time, each time it happens, whether that's every day or once a month or less than that. It tends to be a stereotyped event. And if the aura is alone, then that is what we used to call, or what we now call, a focal onset aware seizure, and what we used to call simple partial seizure. And again, we'll go over more of this terminology again and again. Now, some common auras that patients with focal epilepsies present with or will tell you about can be abnormal thoughts, such as recurrent deja vu, or the feeling that you've experienced a situation, a scenario before, even though you've not. or jamais vu, meaning, again, the French word for meaning something, a feeling that something is unfamiliar, even though it should be. Or sudden onset fear or panic without any clear reason, or the opposite, pleasant feelings that just seem to come out of nowhere. They can be abnormal sensory perceptions, and that really can affect any sensory perception that our bodies have. So sense of smell, sense of taste, sound, or vision. It can even be a feeling, numbness or tingling in a body part. It can even involve kind of this nausea, or what we refer to as abdominal gastric rising or stomach rising sensation. I had a young patient one time describe these sensations as feeling like she was going over a roller coaster multiple times per day. So it really can involve lots of different sensations, and it really does depend on where in the brain it's coming from. The middle, or what we call ictal event, is what most people think of when they think of the seizure itself, though. And we'll talk more about a variety of these different ictal events later in the talk, so I won't belabor it here. And then lastly is the end of the seizure, or the post-ictal period. And this is usually after the seizure is done. It's the recovery period after a seizure. Now, this period of time can be very brief, seconds to minutes, or it can be hours. It depends on a variety of different things: the age of the patient, the state of the patient, the length of the seizure. I refer to this period of time as the computer is sort of rebooting. And you see that on an EEG in an electrical sense after somebody has had a seizure, as well as just kind of in the clinical sense, where the patient is sort of coming back online again, and you can kind of see they're coming back to awareness, but they're still not fully there yet. And just like when a computer has a computer error or freeze, and you have to reboot the computer, it doesn't turn on right away. It takes some time to sort of go through the processes to come back to its normal running state. And the brain is the same thing after a seizure. So what is not a seizure? Well, what we refer to as interictal electrical abnormalities. So interictal being in between the ictal events, or in between the seizures. We will still sometimes see abnormal electrical activity in the brain. We often refer to these as spikes or sharp waves. And I tell patients and families, this is like skipped beats in a brain. It's not a sustained change. It's not associated with any clinical manifestation, so we don't call these seizures, but these can certainly predispose somebody to a risk of having a seizure. And usually, and I say spikes do not equal seizures, and that's usually the case. Again, there are caveats to almost everything I will say throughout this talk. And this is just kind of a visual representation, a cartoon representation of what we see on the EEG, the spike and slow wave afterward. And there are certain aspects of how we describe these things, and certain aspects that are criteria that you have to meet when we're reading an EEG to call something a spike. And then next to it here is actually a representation of a spike and wave on an EEG in a patient who's asleep. So what is epilepsy then? So epilepsy is a brain disorder that causes recurring unprovoked seizures. Sometimes, we refer to this as seizure disorder, and essentially they mean the same thing. And it just means somebody whose brain makes seizure on its own. It does not state anything about the cause of their seizures. There can be certain triggers for patient seizures, but not always. And these things can include things like sleep deprivation, photic stimulation, stress. And so that's why we do some of these provoking measures during an EEG to try and trigger or provoke a seizure in patients that have epilepsy. But it's not being caused by that trigger. Their brain just makes seizure on its own. What is not epilepsy? Well, epilepsy is different than what we refer to as an acute provoked seizure, which is often or typically not classified as epilepsy. And these can include seizures that febrile seizures, so a common problem that I see in my practice, because that is a type of acute provoked seizure that occurs in toddlers and is probably the most common pediatric neurologic emergency. But you can have seizures after an acute head injury, a TBI, seizures associated with an acute stroke. And typically none of these in that acute period, right after the injury or stroke, is associated with epilepsy. However, sometimes patients can have provoked seizures and then go on to develop epilepsy later, i.e., developing recurrent seizures after a stroke. So if they have a stroke and then have a seizure at the time, but then go on to have additional unprovoked seizures later after their stroke or after their injury, then that's what we would call epilepsy. Or in some cases, patients that can have febrile seizures, again, back to the pediatric world, febrile seizures, or what we call febrile status epilepticus, can go on and can develop epilepsy later in life as well. Additionally, non-epileptic events are not epilepsy either, but we won't cover those today. We're mainly talking about epileptic seizures in this sense today. So there's a classification of seizures. This was sort of the physicians, as part of the national groups, regularly kind of reviewed these things, and this most recent re-review or classification took place back in 2017 through a consensus of physicians around the country and world. And essentially now we kind of break seizures down into three main categories. You have a focal onset seizure, a generalized onset seizure, or an unknown onset. And under the focal onset, you can have awareness or impaired awareness, and you can have motor or non-motor seizures. And so I call these seizures, and I sort of added to this picture. This picture was taken from the Epilepsy Foundation website, but I sort of added to it. I refer to these seizures as forest fires, and we'll kind of talk a little bit more about that later. But essentially, a focal seizure is a seizure that starts in one area or region of the brain. Sometimes it can be more than one. Sometimes it can stay in that region or stay local to that area, or it can spread like a forest fire can. Sometimes it can even join up with other seizures arising from other parts of the brain, depending on how frequent they're occurring. Just like a forest fire can kind of start small and then spread to involve more of the forest if the conditions are right. Then you have generalized onset seizures that typically have impaired awareness. And I added to this usually. Again, there's caveats to everything. And again, these can also include motor and non-motor types of seizures. And then lastly, you have an unknown onset, where it's not clear whether or not this is focal or generalized at its onset, at its start. And again, those can be motor and non-motor as well. And usually that's a diagnosis where you're just not sure yet, or you're waiting additional information, or for the patient to have more history, have more seizures, and then it becomes more clear over time. And to go back really quickly, sorry. So I also added this to the generalized onset seizure that I said, I call these the light switch seizures. These are seizures that basically the lights go out all simultaneously, all at once. And often there is not a warning that the patient has, because it affects the whole brain all at the same time. And then eventually when the seizure is done, the light switch comes back on again, and the power comes back on. So again, to kind of reiterate that, so generalized seizures typically affect both sides of the brain simultaneously, and usually all parts of the brain at the same time. And so that's why I call them the light switch. It's like the lights just go off, and then eventually they come back on again. Versus focal seizures, or what we used to call partial seizures, that tend to start in one area or one side of the brain, but that can spread. And so that's why I kind of refer more to those to the forest fire. And so now looking at some specific types of seizures. So we're going to look at some of the generalized seizures first, and ones that have more motor components to them. Starting with the generalized tonic, clonic, or GTC seizure. So you'll see these words out there, from time to time. Or we refer to these as generalized convulsive seizures. These are formally called grand mal seizures. Grand mal just meaning big bad in French. And so 50, 60 years ago, when the French were trying to kind of sort out these different things, they said, well, these are the big bad ones, and then we'll talk about the little bad seizures later. So they had grand mal and petit mal. Nowadays, like I said, we've gotten away from that older terminology, but I still have frequent patients that know of that terminology. These are the seizures that most people are familiar with. These are the ones that I tell families and patients, these are the ones you're going to see on bad daytime television or Grey's Anatomy or, whatever the medical drama is du jour, because they're very dramatic. They're very, and so, of course, they get acted out, although usually poorly, by different actors on screen because of that dramatic and nature of it. So they're called tonic clonic because they include elements of both of those features. Tonic, meaning, is the word that we use for the stiffening portion. So this is usually first or at the onset of these types of seizures where the whole body sort of stiffens up. The patient may exhibit a groan or a moan, and that's usually because the muscles that are involved in breathing are also stiffening and contracting. And so it's almost like they're also pushing air kind of uncontrollably out through their vocal cords. They often will fall because of this portion of the seizure as well. And then after that, it sort of goes into that more rhythmic jerking. That is what we refer to as clonic. This usually comes later into the seizure, but it can be seconds into it. So you may miss that initial portion. And this rhythmic jerking is usually synchronous in the body. So the arms and legs are together. Sometimes they'll even have eye blinking associated with it or facial grimacing that's in synchrony with the jerks of the body. There's evolution over time. It usually starts faster and then will eventually slow down sort of as the seizure is progressing and kind of coming to a stopping point. So it may be more rapid at first, one every less than second, 1 or 2 per second. And then as the seizure progresses, it tends to slow down to maybe 1 a second or 1 every other second before it finally resolves. During a bigger seizure like this, for lack of a better term, the patient may have change of color, meaning cyanosis, because again, those breathing muscles are contracting the same way that the rest of the body is. And so they often aren't getting quite as much air into their lungs. So they may turn a little bit blue around the lips or the fingertips because those are highly vascularized tissues that change color rapidly. But they may change color further, which actually may be cause for concern in a medical emergency. During this time, they may bite their tongue or their cheek if they're laying down, especially because that's what we typically tell patients who are having it, or I guess family members or caregivers of patients that have generalized tonic-clonic seizures. Lay them down, turn them on their side, but they may bite their tongue during this because their jaw muscles are contracting or clenching too. They may vomit excessively or drool excessively during a seizure like this because of the autonomic changes that come with a big seizure like this, and which is the main reason why we tell you to turn them on their side, so that will just kind of drain out and so that the patient won't choke on it. They may urinate or stool incidentally, usually at the tail end of the seizure as the body is sort of relaxing and coming out of the seizure. And there's typically a loss of awareness with these seizures because, again, like I said, the brain essentially completely goes offline into this abnormal rhythm. And so therefore, there is usually a loss of awareness. And it's not uncommon actually for patients to have amnesia from this event. So they don't often have, with generalized onset motor seizures, they often don't have any awareness that it's coming. It just happens. The light switch flips. But then they can also have some amnesia prior to or after the event. We call that anterograde or retrograde amnesia. Sometimes patients can forget an hour or more, a whole day before the seizure event of anything that happened to them. Typically, these seizures last a couple of minutes before they resolve. Most often, seizures resolve spontaneously. But if they persist, as I mentioned before, longer than a few minutes, then that person may be progressing towards that medical emergency that we refer to as convulsive status epilepticus. And these types of seizures can be associated with lots of different types of epilepsy syndromes or epilepsies. And they can also be focal to secondary generalized. A seizure can start as a focal aura, and then can turn into a bigger seizure like this. That process can take sometimes seconds or a second before it rapidly generalizes. In some patients, it can take minutes, or it can, never happen. And so that's why, again, it goes back to that forest fire, kind of starting smaller and getting bigger. Another type of generalized onset motor seizure is what we call a tonic seizure. So this is, again, that whole body stiffening without progression, though, to a tonic-clonic seizure. So these seizures are typically brief, 5 to 20 seconds, and don't have that progression, as I mentioned earlier. Patients with these seizures, if they, are mobile and ambulatory and walking, and the seizure occurs, they can fall, and certainly often do. They will often have a loss of awareness if that seizure is of generalized onset. These seizures can also be focal onset. So you can have focal motor tonic seizures. You can have generalized onset motor tonic seizures. If they're focal, depending again on where in the brain it's coming from, it can just involve tonic stiffening of one part of the body. These, when they are generalized onset, are often associated with one of our more severe, unfortunately, epilepsy syndromes that we do see, called Lennox-Gastaut syndrome, and is often mixed with a variety of other seizure types in that situation. Another type of seizure is generalized clonic. This is usually rare as a generalized onset seizure, but it can happen, where you just have that rhythmic repeated stiffening and relaxation of the muscle, which is what causes that rhythmic jerking with a clonic type of seizure. And often this cannot be stopped by restraining or repositioning the limb that's involved. So in the pediatric population, this is something that I often tell my patients to do, particularly of infants that can have focal clonic seizures. You put your hand on it, and now, a parent restraining a child, they'll be able to hold down the limb, but I often will still say, you'll still feel the arm jerking despite that underneath. And so that often is a situation that may be seizure and coming from the brain, as opposed to a variety of other neurologic movements that can often look like this. In isolation, as I mentioned, it's rare, and when that does occur, it's actually usually a focal onset. So it's rare to have a clonic generalized onset seizure, but it can happen. Another type of generalized onset motor seizure is what we call a generalized myoclonic seizure. So these are a little different than clonic seizures because they're usually less repetitive. A clonic seizure implies a sustained kind of rhythmic, repetitive jerking movement. In a myoclonic seizure, it's usually just a single brief, sometimes we describe it as shock-like jerk of a muscle or group of muscles, and it's typically less than a second. Sometimes it can be a little bit more long, over 1 to 2 seconds, but again, typically brief and shock-like. And we actually use the same terminology to describe the same movement that probably everyone in this room has experienced before, called sleep myoclonus, where you sort of suddenly jerk yourself awake. And the myoclonus just describes that movement, that jerking movement of your muscles. When it occurs in sleep in an otherwise healthy individual, it's normal, and we call it sleep myoclonus, and we all experience that. But if it happens in wakefulness or happens in sleep but is associated with an EEG change, like a spike and wave, then we call that a myoclonic seizure or epileptic myoclonus. Now, these can occur in isolation, just one, and then not recur, or they can occur in clusters repeatedly over a period of time, sometimes hours. And when that does occur, they can lead to falls as well and injuries, just like with the tonic or tonic-clonic seizures. This was the one caveat I did put because it says even when they cluster, a lot of times patients may not lose awareness with that. And I've seen patients have clusters of these brief myoclonic seizures once every couple of seconds for sometimes many minutes or even hours.
but they don't lose awareness. We actually call that status myoclonus. And it's sometimes a finding in patients with juvenile myoclonic epilepsy that have not started a treatment yet, who maybe they stayed up all night. They'll have a series of these myoclonic jerks for several minutes or even longer. Sometimes they'll resolve, or sometimes it can then go into a generalized their first time generalized tonic clonic seizure, which then leads them to an eventual diagnosis. So this is the one caveat to the generalized seizures where the patient doesn't actually always lose awareness. These seizures, as I've mentioned, can be triggered by sleep deprivation. They can occur early morning hours in an otherwise healthy teen. When that happens, that's a very consistent finding in somebody with something called juvenile myoclonic epilepsy, which is one of our epilepsy syndrome types. But they can also be associated with a variety of other epilepsy syndromes, including Dravet syndrome, which is what we refer to as early infantile progressive myoclonic epilepsy, or Lennox-Gastaut syndrome, or progressive myoclonic epilepsies. Another generalized motor sort of seizure is what we refer to as a generalized atonic or astatic seizure. These are, so AKA, are drop seizures or drop attacks. So as I've already mentioned, so these are the ones that we call typical drop seizures. As I mentioned earlier, though, there's a variety of different types of seizures that can result in a fall or a drop, quote unquote, and an injury. But this is the one that we refer to as more of a typical drop. And the difference is from this seizure to, say, a tonic seizure or a myoclonic seizure that leads to a drop and a fall and an injury, this is actually related to a loss of muscle tone and a fall. Patients with these, unfortunately, they can cluster, and patients can have, head injuries, or they can be, not full body and just like little head nods where the patient doesn't completely fall to the ground. These, again, are usually also very brief, just 1 second, but they can be a little bit longer, up to a few seconds. And they can, as I mentioned, can also cluster as well. And it can be very hard sometimes to differentiate this type of seizure without video or without EEG, certainly, between this type of seizure and some of the other types, because there is certainly a lot of overlap. And then obviously, too, this type of seizure can occur in a variety of similar epilepsy syndromes, along with some of these other seizure types like myoclonic seizures. So like in Dravet syndrome or Lennox-Gastaut syndrome, which is what LGS stands for, or another syndrome called Deuce syndrome. So again, these things can coexist in the same person and be very difficult sometimes to tease apart, especially for the layperson or even myself when you're just looking at the patient without having that additional EEG information on top of it. Epileptic spasms, unfortunately, is another type of seizure that I will sometimes see in my practice. And these are, again, a lot of overlap with some of the other seizure types, but these are, we sort of carve these out as a separate type of seizure. These are brief, often 1 to 3 second extremity or body flexion or extension tonic stiffening of the body. These can, again, be seen in isolation, or they can cluster together. And they can also sometimes be very subtle, sometimes just involve one arm or even just a subtle facial grimace, especially once a patient has been put on certain treatments for these types of seizures. Now, when these types of seizures occur in infants, we call them infantile spasms, and that is a very specific diagnosis that has its own prognostication and its own etiologies or reasons for it. But they can occur in older patients as well, particularly when it's associated with other types of, more severe epilepsy syndromes, again, like Dravet syndrome or Lennox-Gastaut syndrome. And again, these two can also be focal onset or generalized onset as well. So you see a lot of overlap and crossover here. Now, so to get away from the motor seizures, and now to talk about some of the non-motor seizures. So the most typical one we refer to as a generalized absence seizure, or what we refer to as a typical absence seizure. As I mentioned before, we used to call these petit malls. So these were the little bad seizures. And these are characterized by usually an abrupt onset, behavioral arrest, some staring, some unresponsiveness. They may have a blank look on their face. Their eyes may even kind of turn up or flutter, or the eyelids may flutter slightly during the seizure. They may have other automotor movements, like playing with a zipper, or just kind of fumbling like they're trying to open a button on a shirt, or may smack their lips, a little bit during these events as well. These types of seizures typically last about 10 to 20 seconds, and then the patient goes right back to normal again. As I showed you on that EEG, there's an abrupt onset, an abrupt change. It lasts for 10 seconds, and then they go back to their regularly scheduled programming, like nothing ever happened. So often there is no end or postictal period with these types of seizures. They may be briefly confused. Often it's because, especially in adults, they're unaware that these seizures are happening, but sometimes, especially in very precocious kids too, I sometimes will hear that there is a sense of lost time. They get lost in the conversation. What were you saying? Sorry about that. But a lot of times these can be misdiagnosed as inattention, daydreaming, ADHD. In childhood absence epilepsy, these can be very frequent, sometimes 3 to 5 per hour. It's not uncommon for me to see a patient in my practice who will have 3 or 4, sometimes even in the first half hour that I'm sitting there speaking to them. And, within the first 5 or 10 minutes, we have our diagnosis, and then we can kind of move on with the visit. And we will sometimes see these seizures in different epilepsy syndromes. As I mentioned, childhood absence epilepsy, or something called juvenile absence epilepsy, which, is usually onset of seizures a little bit later in life. Whereas a childhood absence epilepsy typically affects early school age children, ages 4, 5, 6, 7, somewhere in that range. There can also be what we refer to as an atypical absence seizure. So these are absence seizures that don't quite fit the profile that I just mentioned. The EEG may look a little bit different. These seizures tend to be a little bit longer in duration than the 10 or 20 second. They can have more of a gradual, slower onset or slower offset. As I mentioned, there can be more prolonged confusion associated after it. It may not be entirely clear when the seizure is over. Sometimes they can go back to back to back. There are similar symptoms, though, associated with these seizures. Again, staring, unresponsiveness, the eye or eyelid fluttering, the automotor activity like the lip smacking or rubbing fingers. When we hear about atypical absence seizure, again, these can also be seen in a variety of different epilepsy syndromes like Lennox-Gastaut syndrome, Deuce syndrome, as well as others. All right, so now moving away from the generalized onset seizures to more focal seizures. So these are the ones that we used to call simple partial seizures. These are the ones, or what we now refer to as focal aware seizures. In these seizures, there is no loss of awareness by the patient. The patient is often aware of what's happening around them during this time. And as I mentioned previously, the symptoms that the patient will describe or that caregivers will see often very much depends on the location of where in the brain this is coming from. Or if it's not where it's starting, where is it spreading to? And so these seizures usually get divided into non-motor, which can include things we refer to as psychic, not psychic in the sense like mind reading, but psychic in the sense of thoughts or feelings. As I mentioned, déjà vu during the aura portion, déjà vu, jamais vu, feelings of panic. Sometimes we'll separate panic or feelings into another subset called emotional onset seizures. As I mentioned before, the sensory, these are those hallucinations essentially is what they're experiencing, the sense of smell, sense of taste, sense of tingling or numbness in a hand or foot, sense vision changes. They can have autonomic features, so their heart rate will just skyrocket all of a sudden, or they can have other vital sign changes, piloerection, or what we refer to as those goosebumps that patients will get. Or they can have motor seizures, and that can include a variety of any of the types of motor seizures we actually refer to. So focal clonic jerking, focal tonic stiffening, weakness, atonic, tonic clonic. Any of these seizures can be focal motor type of seizure as well. And then you have focal seizures with impaired awareness. And so these are the ones that we used to refer to as complex partial seizures. And again, you'll still hear this terminology kind of thrown around. And sometimes these can often be confused with or called absent seizures, especially when it's a focal impaired awareness seizure that's non-motor. There's no motor manifestation associated with it. There still may be a prodrome or aura. The patient may remember it. It can start as a focal aware and then turn into a focal impaired aware sometimes as well. There may be more postictal confusion or fatigue, like with these types of seizures. They tend to be longer in duration, so greater than 20 seconds, but not always. And these tend to be less often than absent seizures. So they tend to be, daily or less than that, as opposed to like a typical absent seizure, which happens quite frequently, multiple times a day, sometimes multiple times per hour. And these can sometimes also become secondary generalized as well. And there are a few types of special seizures that I just wanted, honorable mentions here that I have seen rarely. One is called gelastic seizures, and another is called dichristic seizures. So these are usually focal seizures that start or involve what's called the hypothalamus, which is a part of the brain that is deep. Often associated, at least in pediatric patients, with something called a hypothalamic hamartoma, which is a type of mass lesion that can affect the hypothalamus and can cause or lead to these types of seizures. And so gelastic seizures is usually what we refer to as laughing seizures, and dichristic are crying seizures. And interestingly enough, they can occur in the same patient for the same reason, and they often can sound kind of the same. When they do occur, neither are associated with the emotions typically associated with those with laughing or with crying. A lot of times patients will say, I don't know why I'm laughing, I don't know why I'm crying. And it's often, when I have seen patients with this, it's often a very unnatural. It's not a normal laugh, it's not a normal cry. It's often, when it's crying, it's often very high-pitched and irregular sounding, or laughing is often, again, very high-pitched and almost unnatural or eerie, spooky in a lot of ways. So why is this important? Well, I feel very strongly about this because, and I've actually even talked to a lot of my colleagues even recently, because it can be helpful to know what you're looking for in a seizure, because it's one of the most helpful tools that we have to help with an accurate diagnosis. And sometimes, unfortunately, unless the episode is captured on video, an accurate history of what the episode looks like is sometimes the only information I have to go on to diagnose you with epilepsy or seizures. And so because of that, having knowledge of what's out there, what kinds of seizures can occur, can be very helpful in diagnosing or even just monitoring how a patient is doing and how frequently their seizures are occurring. Often we do that with seizure diaries, but unless the patients or caregivers know what to look for, sometimes that information isn't always very helpful. But a lot of times that information is all that we have to go on to make our treatment decisions moving forward. And then secondly, appropriate treatment, as I just mentioned. Should we pick a different medicine? Some of our medicines work really well for focal seizures, but they can harm even patients, or at least not help patients with generalized absent seizures, for instance. And so is the patient having general absence epilepsy, or do they have focal non-motor impaired awareness seizures? And differentiating those two things is extremely important because it can affect their treatment. Trileptal is a wonderful seizure drug for focal seizures, but I have seen it push patients into absence status epilepticus with a prolonged staring and drooling for sometimes 30 minutes or more, because that medicine can do that sometimes to patients that have generalized absence epilepsy. And then lastly, you know, we always say surgery is the gold standard, and surgery is a great option for many patients with focal epilepsy, but it may not be an option if you have a generalized onset seizure type. And so that's where this accurate diagnosis then can also lead to more appropriate treatment for our patients and getting them the help that they need. So with that, I have a few references here. I thank you all for your time and be happy to sort of answer any questions that anybody might have.
May I ask you a question?
Yeah, sure, certainly.
I actually feel terrible about something that happened to me a long time ago. I had brain surgery in 2009. I was diagnosed when I was 4 years old, but anyways, I I had to have brain surgery in 2009 because I had a seizure, a really bad seizure when I lived in Florida. But anyways, after my brain surgery, I was having auras and but I was driving and I drove all the way till 2019. My auras did end up stopping, but I was concerned that something might have happened. So when I was reading your information, I was like, "Oh no, why would they have let me um drive if that's what I just read, that an aura is a type of seizure when and if you're gonna have a seizure, then you shouldn't be driving." You know what I mean?
I know what you mean, and that's a very tricky situation to navigate. That's why I'm actually very thankful I see pediatric patients, because it's not one. Most of the vast majority of my patients are not even of driving age yet. And you're absolutely right. Now, again, it's a situation where the aura is, you know, again, if it's something that's stereotyped. For instance, I have patients that tell me, yeah, right before I have a seizure, I get this buzzing noise or I get this rising gastric sensation. And that, unfortunately, that is the seizure. When we put you on EEG, sometimes we will see that change in the electrical pattern. Now, it may not lead to a loss of awareness, and it may not progress, especially if somebody is on medication to help prevent seizures. And you know, it is, and then you take driving into it, and driving's tricky because it really is a decision-making process. It's not cut and dry. It's not black and white. Certainly for some people it is. And I've even met doctors that have said, no, if my patient's having any kind of seizure, they do not drive, period. And there are some states that have laws that say that too. And it doesn't specify type of seizure, length of seizure, loss of, right, exactly. You know, you're 100% correct. There's no,
I just feel
and
terrible now that I did that.
well, I think there's a couple of things. The first is you can't go back in time, right? You can't
Right,
rewrite the past, and what's done is done.
right,
Secondly, now you know, right?
yeah, right.
And so moving forward, if you were ever able, you know, if that's something that you ever experience again, it's something that you probably want to talk to your neurologist about, right?
Yes.
Because maybe it is something that it requires some tweaking or adjustments to your treatment or medication, or exploring other treatment options to make you safe.
Right,
You know,
right.
epilepsy is a very common disease, common problem. And I tell patients this every day, especially usually when I'm counseling parents of patients who are 16 years old who want to start driving for the first time, right? And I
Mm.
tell them, well, epilepsy affects like 1 in 26 people, depending on what study you look at. 1 in 26, 1 in 33. There's different studies out there, but it's really common. And so if you drive by 33 people on the, on a day basis, one of them probably has epilepsy and they're still driving, which usually makes the parents' eyes pop out of their head and
Right.
their jaw drop to the floor.
Right.
But the reality is, if your seizures are well controlled, then and you're not having ongoing seizures, then people need to drive. We live in a country that you absolutely need to be able to drive in most of the time, unless you live in a big city with public transportation. So,
Well, I just want to let you know that it was nice that that information was right there because I did not know that an aura was part of, no, not part of,
it is.
that it is a seizure. So,
Yes, indeed.
so because I was really, I've been seizure free since September, but then I had a seizure in February, so I have to wait till August to see if I can drive again. So, but
Yeah.
but now I'll know though that an aura is a seizure. So,
Thank you very much, Courtney, for all of your questions. I think we have a couple other questions I seen in the chat.
oh no, I'm done.
Okay.
All right. So, next, can you guys hear me? Next, we have Becky. She wants to know if Diastat, if you recommend Diastat for a one-time staring seizure.
Again, it sort of depends on. That's a tougher question, and believe it or not, you'd think. For me, it would depend on the age of the patient, what's going on. Was it really just a one-time event? Because I will tell you, so when I see patients for staring episodes, when they're seizures, as I mentioned, it's typically childhood absence epilepsy, and those events are not a one-time staring event. Those seizures are, like I said, 3-4 times during our visit, and so are very clear. Nonetheless, it typically affects younger patients. Those seizures typically are not prolonged, and they don't often go into generalized convulsive seizures, which are the ones that can be more dangerous and certainly life-threatening. And so actually, I don't typically prescribe Diastat or any seizure rescue medicine for patients that have recurrent absence seizures alone. We just try to manage your seizures. I don't know. That would depend on a lot of other factors. What does their EEG show? Because if it's a one-time seizure and just a staring episode, I tend to say, well, was it really a seizure? That's the first thing. If we think that it was, then it's still a first-time seizure, and you don't necessarily qualify for a diagnosis of epilepsy yet. Until you've had at least 2 seizures or 1 seizure and then testing to suggest that you're at risk for having additional seizures. So that would be things like an EEG, in which case then that would also play into the decision-making process. And lastly, what was the length of time of the seizure too? Was it a 5-minute long staring episode, but they didn't jerk or shake? That's more concerning to me than something that was 10 or 20 or 30 seconds. So good question. One that would need a lot more context to answer, though.
All right, and then we've got another question. Someone asks, can you review the benefits of having a seizure monitoring device, such as the watches for children? Do insurance companies pay for them, and about how much do they cost?
Great question. I think the last time I did a talk for the Epilepsy Association, it was about this very topic, actually. I did a whole hour on seizure detection devices. In short, I have a number of patients that have them. I have a number of patients that don't. And some of those patients that have them have very frequent seizures, and others have infrequent seizures, and vice versa. they are not great devices for detecting anything other than generalized tonic-clonic seizures. And so I think if you have a patient that is off on their own, that has those types of seizures, those are the ones you want to detect. And so I think, for teenager patients that are off on their own a lot of the time, having those devices and who have generalized tonic-clonic seizures, these devices may be helpful. Insurance companies, unfortunately, do not pay for them. And how much do they cost? I mean, anywhere between, a few $100s for an iWatch with the app, or for the, it's not Embrace now. And maybe it is still called the Embrace. I forget what they call it now, but the Embrace 3 is the newest device, I think, is like $350. There's also monthly service charges or regular service charges that go with those devices, and up to thousands of dollars for things like the infrared video cameras. So a very good question, but again, one that we could do a whole hour on just by itself. And then somebody said seizure dogs. Again, those are sort of hit or miss as well. I have a number of patients that have seizure dogs. They're sweet animals. They bring them to their visits. But I've also seen seizure dogs that, the patient seizing in the EMU and the dog's asleep. So, I think it's, again, things to look into, but not all, well, if it's a well-trained dog from a reputable place, I think it's something reasonable if that's something that you wanted to do. Let's see. Curious about epilepsy and dystonia. Is this after effect in these cases? What can be done helped coming out of one of these spells? Carl, would you mind elaborating a little bit, I guess?
Well, this is what I've been treated for the last year, and it just seems like that preceding the dystonia episodes, I am going through something that just makes me feel like I have a truck that just ran over my head a few times. And yeah, and again, I'm having these things that happen at night, so it's hard to exactly put down on paper what's happening.
Gotcha. Well, dystonia in general is kind of like myoclonus, is more of a, in neurology, is more of a description of the movement. So it's usually a posturing, a lot of times a tonic posturing of a limb. In general, though, dystonia is usually thought of as a subcortical manifestation, usually involving motor, other parts of the brain that are involved in motor coordination and movement, but certainly can be the end result of a seizure or associated with seizures, and we will see that as well. As far as, epilepsy mainly being a cortical problem, it's a problem of the cortex is the actual brain cells, the gray matter of your brain, and that's actually where the electrical impulses start. The white matter being kind of where the wiring bundles that carry that signal down to the rest of your body. And then there's other structures of the brain that are involved as kind of like relay stations, grand central station, like the thalamus, for instance. And so obviously there's an interplay in all of these things, and patients can certainly have dystonia, they can have seizures, they can have both. I would say in a situation like this where it's not clear, I think having video EEG is certainly a very powerful tool, because if it's a seizure that's causing the dystonia or dystonic movements, then that's usually one treatment, and then if it's dystonia alone, then there are actually other treatments that you can try that can treat dystonia that aren't related to seizure medications. And then this is all like, but just to clarify how blurred these borders are, there's a type of what we call paroxysmal dystonia that occur in adults and children, often presents in childhood though. But the treatment is a seizure medication, trileptal, and it's not caused by a seizure, but for some reason a seizure medicine treats it. So who knows? So, a lot of hand waving, but this is a situation I think where EEG can be very helpful. So hopefully that answered your question. Thank you for the question.
All righty. Thank you, Dr. DiSano, for answering all those questions, and thank you for the presentation. That was wonderful. And of course, thank you to everyone who tuned in today. I hope you found all this information helpful and informative. After the seminar concludes, we're going to send you guys a seminar. So if you could, or sorry, a survey. So if you could fill that out for us and just kind of share your thoughts, that would be great. I also want to thank our sponsor, SK Life Science, one more time. And I wanted to make note of some of our upcoming events as well. In August, on August 17th, we have our Outrace Epilepsy 10K, 5K, and 1 mile fun run at the Cleveland Metro Park Zoo. That'll be a great time, great for kids as well. And then coming up on June 23rd, if we have any golfers at the we will have our annual golf outing at the Sweetbriar Golf Club in Avon Lake. And coming up in August as well, we have another seminar on epilepsy self-management and the SMART program. So keep an eye on your emails and social media for that. And once again, thank you all for attending, and we will have the YouTube link sent out to you as soon as it's uploaded.